It's the 21st of November, 2025. This is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. This week on the podcast, we'll talk about preventing disease with colchicine and romosozumab. How about monitoring disease by ferritin or IL-1 receptor antagonist? And we all know what to do when the ANA shows up, right? Well, we're going to actually talk about vitamin D. You love it. I'm bothered by it. Let's see what the data shows. First, a study of lupus nephritis, 136 patients looking at the natural history of steroid use in this cohort. They followed these patients for 121 months. The mean time to wean steroids to 7.5 milligrams a day was 9 months. To 5 milligrams a day was 12 months, and to get off steroids was 29 months. So not too bad weaning, but obviously not good enough if the goal was getting off. The predictors of a shorter time to discontinuation was having a sustained complete response or a SLEDAI of 4 or less, having membranous lupus nephritis, and being on hydroxychloroquine. If you were on steroids for a long period of time, guess what? You had more renal flares and more organ damage. That goes without saying, does it not? Why else would you be on steroids? But in this era where we're talking about trying to minimize steroids and get to very low or no steroids, this data is important, telling you it's still a challenge, it's still in your court, and it still is either your responsibility or your fault, or maybe your accolades if you're good at this. I was raised in a very lupus heavy environment, a county hospital, where I found that getting totally off steroids was not a good idea, but getting down to 5 milligrams or less was probably a good idea. There are others who believe this, but I think some of our leaders right now, including Michelle Petrie and others, are really advocating for getting off steroids whenever you can. A good idea. A recent study caught my eye about prevention of osteoarthritis, either hip, knee, or hand, or OA. And in this target emulation trial, they looked at 12,145 patients, older, mostly female, mostly 80 years of age. And they showed that when you looked at women on romosozumab, the sclerostin inhibitor, or versus teriparatide, PTH targeting, that you had a significantly lower risk of developing mainly OA or in general, but specifically knee OA, where there was about a 20 to 21% lower risk. Hip and hand OA was also lower, but not to statistical significance. There was still, in the confidence interval, still overlapped one a little bit there. So there was this trend with romosozumab, and I put this up there because there has been data out there about, for a long time, about bisphosphonate use may lower the risk of osteoarthritis. Conflicting evidence, certainly not conclusive. I did trials early on where we looked at bisphosphonates trying to retard X-ray erosions in rheumatoid arthritis. And there's always been this idea that, better bone metabolism drugs, if you will, might lead to better bone outcomes in general. The mechanisms as to how romosozumab would be better than teriparatide or paraparatide, I'm not too certain of. But I find this interesting, and I think is another call to use these more aggressive therapies in managing osteoporosis. A recent Cochrane meta-analysis weighed in on something that we have talked about in the past. Does colchicine lower cardiovascular risk? Does it lower the risk of MI? This was a Cochrane review of, what's the number of patients here? It was large. It was 12 studies, 22,900 patients compared to 11,000. Of the 22,000, half of them, or 11,000, were on colchicine. They found overall good evidence that colchicine lowers the risk of MI by 26% and by stroke by 33%, those being significant. Overall, colchicine did not give an increased risk of serious adverse events, but we know colchicine does increase the rate of GI events in over 50-60% of patients who take the drug. I do think chronic colchicine use, which I don't use much of, I must say, is good at retarding expert outcomes. And this is why the cardiologists are in favor of colchicine for a lot of indications in the cardiology world. A market scan claims data study looked at the infection rates with adalimumab, either in hidradenitis suppurativa or psoriasis. And what do you need to know here? You need to know that serious infectious events in the pre-biologic era was 9 per 100 in RA. When you're doing great in clinical trials and drug development, you're at like 1 to 2 per 100 patient years. When you're doing bad, you're closer to 9. Most of the drugs in TNF inhibitors, for instance, in RA, were in the 3 to 6 range, right? But what happens in other disorders? And it turns out, as I said last week, that other disorders are either as dirty as RA, and that includes inflammatory bowel disease, right? Or much cleaner than RA and IBD, and that's psoriasis, with psoriatic arthritis falling in between. So in this study, they looked at adalimumab, a popular TNF inhibitor, and rates of infection with hidradenitis suppurativa, which I say is dirtier and looks more like RA and IBD. And there, the rate was, or actually, they just gave us a hazard ratio. It was a 53% significant increase in hospitalizable or serious infectious events, and this was especially true for sepsis and genitourinary infections. So it's much higher when comparing infection rates in hidradenitis suppurativa versus psoriasis, which we know has a relatively low rate. And that tells you, again, a lot about expectations when using biologics are not the same across the board. They may differ according to the host and the host disease. I like the study on Still's disease because it's Still's disease, and they looked at ferritin and how useful is ferritin. You guys love ferritin. You're like all gaga about ferritin. No, I'm not. Hyperferritinemia, like 10,000 ferritin and more, is more likely to be due to some other disease than it is to be due to Still's or macrophage activation syndrome, or it certainly happens there. But high ferritins in Still's disease, ferritin being acute phase reactant, is far inferior to CRP and sed rate, those being elevated in over 90% of patients with active inflammatory systemic Still's, kids or adults. Ferritin, 50% or less. In this study, a retrospective review of 113 adult Still's patients, mean age 45, mean ferritin levels at baseline were 4,600, ranging from 1,100 up to 14,000. They looked at the ability of some intervention to avoid advanced therapy need. And here they counted advanced therapies as the use of IVIG, IL-1, or IL-6 inhibitors. This was a study a few years ago before IL-1 and IL-6 became the standard of care. In this cohort of 113 patients, 13% required advanced therapy, IVIG, IL-1, or IL-6 inhibitors. These were not predicted by ferritin levels. The ferritin levels were continually high, sustained high. It would tell you who's got the worst disease, is going to need the more aggressive therapy. Ferritin was not a reliable biomarker in Still's disease. Ferritin is a very good biomarker for impending MAS, or MAS that's ongoing and active and needs to be treated. But you can order it, just I don't order much of it, to be honest with you. And it tells you in this study it's not a great biomarker. What could be a good biomarker in large vessel vasculitis, which I think in many ways is an autoinflammatory, certainly innate immune system, involves the inflammasome, is the use of IL-1RA. This is a relatively small study of 21 patients who are treatment naive with large vessel vasculitis, 13 with GCA, 8 with Takayasu's arteritis. IL-1RA was 2 to 3-fold higher with Takayasu's and GCA than in those without, where in normals, the IL-1RA levels, and this is a receptor antagonist, which is counter-regulatory to IL-1, right, was 170 picograms. But in Takeyasu's in GCA, it was 385 and 465. Also elevated in large vessel vasculitis is IL-6, but really variable, and so was IL-1 beta and gamma interferon. IL-1 beta and gamma interferon were increased in GCA. IL-17 was increased in Takeyasu's, but it looked like IL-1RA was maybe the better measure and did correlate well with CRP. It should be evaluated in future studies. I like this Japanese study. The ANSWER cohort study was basically 1,000 patients being enrolled on biologics, and they looked at different outcomes of biologics. Here's a subset study of patients in the ANSWER study, 3,600 RA patients that were started on a biologic DMARD or JAK. From this cohort, they found 118 RA patients who were pregnant. And they looked at how good were their clinicians at maintaining a treat-to-target strategy during pregnancy and using biologics. Overall, the 118 pregnancies, 93% full-term deliveries. That's really good. That's really high. 85% were in remission or in low disease activity throughout pregnancy, and many of those were due to the continuation of the biologic DMARD or JAK. That was about over 35% continued therapy during pregnancy. But compared to those who didn't continue, the ones who did continue had significantly lower DAS28 CRPs versus those who stopped. And that was highly significant. Again, this data speaks strongly to the point that control the inflammation and you'll have the best outcome with the baby. And it's not risky to use these biologics. Data is really, really strong for TNF inhibitors. I think it's good for all the drugs, but you should certainly refer to the package insert, talk to the medical affairs people with the drug that you're considering on continuing. An interesting study this week looked at postmenopausal women who were exposed to estrogen hormone therapy, and they showed a modest risk of developing an autoimmune disease. A 33% increase by hazard ratio. That was significant. This was a new autoimmune disorder arising 5 to 10 years after the use of hormonal therapy. This is one of them Trinetics large database EMR studies of almost 900,000 people on hormonal therapy versus 2.6 million not on hormonal therapy. The risk of developing an autoimmune disease if you were not on hormonal therapy was 5.3%. If you were not on hormonal therapy, if you were not on it, it was 6.7. If you were, it was 5.3. It's about a 20-25% reduction 5 years after starting. This is interesting in light of the fact that the FDA did come along in the last few weeks and change the warnings on hormonal therapy and remove the black box warning, suggesting it is okay to use hormonal therapy in postmenopausal women for postmenopausal symptoms and bone benefits, etc. But there's still some concern about cancer and cardiovascular risk, and maybe you wouldn't use it in people with those conditions or at high risk for those conditions. But I think this is interesting data. This is a modest risk. I don't know that this risk would prevent me from using hormonal therapy in a postmenopausal woman. It might in a woman who's got a family history or was worried about that. You'd have to disclose that information. But I think the data is looking better about, and we need to better look at that on RheumNow in the weeks to come, about how you are, in fact, going to use hormonal therapy going forward. A retrospective study looked at the role of ANAs in RA patients. Specifically, we're looking at RA patients who are double positive for rheumatoid factor and CCP antibodies. What happens if they're triple positive? And now you find out that they're ANA positive. 20% of RA patients are ANA positive. But they're in this study of a fairly large cohort, they showed that being triple positive was associated with significantly higher disease activity scores, both at baseline and 12 months later, and a lower chance of actually achieving remission or sustaining remission compared to those who were just RF and CCP positive. So just the added positivity, and triple positivity is bad in I think almost every disease. It basically says heightened immunologic activity that you wish weren't there, and what's it doing? It's doing bad things, at least in this cohort study of RA patients. Again, we're on the topic of ANA. What about ANA positivity in lupus? This was studied by over 2,000 patients who from China who looked at first trimester women and found ANA positivity to be 14.7%. That's what I teach. The population rate for ANA positivity, based on how the test is developed, should be 5 for no more than 6%. If you apply those same cutoffs to a sick population, an elderly population, it's like threefold higher. To a hospitalized population, threefold higher. And to a pregnant population, threefold higher, 14.7%. The most common titer was 1 to 100 low titer. The most common pattern was a speckled pattern. We all see this. ANA positivity in this cohort study was associated with smoking, ages 30 to 34, being multiparous, having thyroid disease, and having hypertension. I like all those, except the head scratcher on hypertension. Not sure what that is, but that's what they found. So this week we reported on Michelle Petrie's ARD study. It was an article written by MedPage Today saying that 25 hydroxy vitamin D levels do influence outcomes in lupus. This was the Hopkins lupus cohort that Michelle's been following serially over time, and a lot of people there at Hopkins are doing great work on lupus. 1,768 patients, and they compared those who had low vitamin D, less than 20 nanograms, versus those who had normal 30 to 39 nanograms per ml. And they showed that if you were low, less than 20, you had a significantly higher mortality rate and cardiovascular event rate. So the ones with the low levels had a rate of death rate of 8.6 per 1,000 patient years versus the normal rate 2.7. That's not good. That's almost threefold higher. So it's actually about twofold higher, hazard ratio of 2.05 for death, and for a cardiovascular event, it's 2.98, a threefold higher risk. So I'm not a big fan of vitamin D research. I do believe in supplementation for bone and immunologic reasons. My problem that I'm seeing a therapist about is that I just don't see the data that giving vitamin D fixes a problem. Show me the data. Now show me two lupus cohorts that got to have a low level and another, and they all have low levels, and half don't get treated and half do get treated. And again, they're kind of saying this, but this is retrospective. It's not quite the same as a prospective study. But I'll believe this, and I certainly will be monitoring vitamin D levels and treating hypovitaminosis D in my lupus patients, mainly because of concern over these outcomes. I like the report this week from the Auto-Inflammatory Disease Alliance registry. Included in that registry, which is many thousands of patients, are patients with Behcet's disease. And they looked at, they cherry-picked 328 Behcet's patients who presented with mucocutaneous manifestations. And they then looked to see how often do they get multi-organ involvement, meaning more than mucosal disease, right? And now we're talking about phlebitis and brain and all kinds of other organs being involved. And what they showed was, I thought, interesting. Risk of multi-organ disease in the future was not associated with minor aphthous ulcers. Minor oral ulcers in the mouth had no risk of no future risk. However, if you had major and minor, now you had a 12-fold higher risk of future organ and multi-organ involvement. Also, if you had major oral ulcerations, aphthous ulcerations, your risk of multi-organ involvement went up when you also had genital aphthous ulcers. It went up 2.5-fold. Pseudofolliculitis, again, 3-fold. And a positive family history of Behcet's, it went up almost 3-fold. Not all Behcet's patients are going to be mild. genital and oral ulceration that you can manage with steroids, colchicine, apremilast, whatever. Okay. Lastly, I like this report on rheumatology supply and demand between 2009 and 2024, published in Seminars of Arthritis and Rheumatism. They used NRMP matched data between in that era, and they basically found a lot of things that should make us really encouraged. We're very worried about, a manpower shortage as the population's aging, arthritis frequency, rheumatic disease frequency is going up, autoimmune frequency is going up. But are the programs and the training, is it going? And this data says, yes, we are doing so much better when it comes to training people for the future, but we're still falling short. Nonetheless, rheumatology programs went up from 99 to 127. That's a 28% increase. Training positions, number of positions that we have went up from 181 to 276. That's a 52% increase. The number of applicants has gone up from 249 in 2009 to 359 in 2024. Again, a 48% increase. And the number of unfilled positions in adult rheumatology went down from 7% to 1%. And not surprisingly, rheumatology has become competitive. There are more people that are not matching with their first choice. Getting your first choice went down from 49% to 33%. Getting your fourth choice went up from like 11 to 17%, 11 to 18%. Rheumatology has become an interesting competitive fellowship and career path. And there are a lot of reasons for that. But this article does point out we are still falling short when it comes to the future of rheumatology and meeting the needs of the population, whether that be for care or for education. So I think, and for this reason, I think that this is why RheumNow in the month of December is going to do a month-long campaign on advanced practice providers. We have a month that's going to be devoted to nurse practitioners and physician assistants and all matters important to them and why rheumatologists should be hiring them to meet the demands of their practice. The campaign is going to be called Mission APP Partners in Care. We're going to talk about APP careers, roles, manpower, and where they fit in healthcare and where they fit in rheumatology practice. We're going to do a lot of disease management in difficult cases, go over diagnostics and therapeutics, talk about complications and comorbidities. We're going to have 4 Tuesday night rheumatologies that are going to go over these issues, and I think you're going to really enjoy them. Again, that's Tuesday night, 7 p.m. in the month of December. Tune in, be there. It's going to be great. I got great panelists who you're going to love to hear from. We're going to do 4 of those. We're going to do at least 12 videos in our therapeutic update series called Underserved and Undertreated and Underserved. And that's going to be a really interesting set of videos. A lot of blogs, vlogs, and plenty of APP QD clinics. Don't forget, RheumNow.live is coming February 7th and 8th, 2026. Fly in a DFW. You can fly in a DFW if you buy a ticket now from either Chicago or Atlanta for like $150, $160. Registration is a discounted registration that ends next week. Get the early bird registration. If you're a fellow or an APP, it's only $55. It goes up 2 or 3-fold after that. Just look at the program, and you're going to want to attend and come to Dallas for this meeting. Just as we begin Saturday morning, February 7th, our first session starting at 8:30 on rheumatoid arthritis, mortality in RA from Elena Mayasadova from the Mayo Clinic, where they have all the data and all the insights. Second lecture, the mucosal hypothesis of rheumatoid arthritis. This is the hot thing in rheumatology coming out of the University of Colorado, and we have Kristen Demerel, who's leading that charge at the U of Denver, U of Colorado in Denver. And lastly, the master himself, Jeff Sparks, talking about ILD in RA. And then we go into step talks, placebos in rheumatology. Andreas Kirschbaumer from Austria, great lecture. Disease modification in osteoarthritis from Tahina Nyoji from Boston. And then we go after that, diet and obesity, mitigating risks for rheum patients undergoing orthopedic surgery from Susan Goodman. We go to lunch, we come back and have a fabulous session on psoriatic arthritis. That's 1/3, one morning from the meeting, and you see it's star-studded, hot topics. You got to be there. That's it for this week on Rheum Now. Tune in next week. We'll see you.